Thank you very much for inviting me. And it is a real pleasure. I'm going to try to put together what is achievable with gene therapy, particularly with gene editing for hemoglobin disorders, for thalassemia and sickle cell disease, and then talk about where I think these therapies may have a place, considering that, as Uta just explained to us, they're incredibly expensive. And so I think there is going to have to be a level of responsibility of how we use if we want to make sure that patients who truly will benefit from them can access to these forms of treatment. So those are my disclosures, just to let you know that I have worked with every single company that is in this area, and so I have no bias towards any of them. The reason why I'm going to be using gene editing as the basis of my talk is because that is the product that is currently licensed in the UK, and that is being considered by NICE. So when we look at transplantation, which we have done for over 30 years, we know that it can lead to a normal life for the patients who have thalassemia and sickle cell disease. And so what I'm showing you there is that the patient enters transplantation with a reduced quality of life. And you can see that there is a variation, but with a median of around 80% of what it ought to be. And that drop because the transplant process is intensive. These patients receive chemotherapy at very high doses, and then have to wait hospitalized within the transplant room for approximately a month to recover the blood production. And then they need to remain on drugs to suppress the immune system in order for the transplant to take on and to stabilize itself for a minimum of 6 months. And so the intensity of the treatment means that the quality of life initially drops. But if you look at it at 6 months after finalizing the treatment, 6 to 12 months after finalizing the treatment, you can see that the vast majority of the patients have recovered normal quality of life. Now, those patients who have not is because they are suffering a complication called graft versus host disease, where the newborn marrow of the donor is attacking the body. And so ideally, you like to be able to do a transplant with the patient's own cells so that they then don't react against the patient, causing any long-term problems, which may be as severe or worse than the original disease that you're trying to deal with. Now, we do know that when transplants are done effectively and they are compared with the best possible medical care, and what you see there is the data from the Italian group, which were the people who originally introduced transplantation for thalassemia. Transplantation in blue shows better outcomes at any of the particular points that you wish to assess it. So particularly in areas of emotional functioning, so the ability to form a partnership with another person, role limitation, which is the ability to maintain your professional life, and bodily pain, you can see that those who have had a transplant are much better off than those who continue with their regular transfusions and chelation treatment. Now, the other thing that we have learned, because we now have very good data from the international registries, is what are the particular aspects which will give you good outcomes with a traditional transplant. And of those, the most important thing is the age at which you undertake the transplant. And so what you see there is data from the international CIBNTR, the international registry in Milwaukee, looking at over 1,000 transplants for thalassemia. And you can see that in those who are young enough, somewhere up to 13, 15 years of age, we are able to provide very safe transplants, whether we do it with a sibling donor or with a fully matched unrelated donor, but that those outcomes are not quite as good the moment the patients start to become late adolescents or early adults. And that is due to both graft failure and the complications of transplantation. Now, the reason for that is that the main complication of transplantation, the fact that the newborn marrow will react against your body, graft versus host disease, is substantially increased in those patients who have iron accumulation in their organs. And so to be able to do a transplant where there is no graft versus host disease, where we are not using someone else's donor cells, will mean that possibly that accumulation of iron in the body over a period of time will complicate less the outcomes of a bone marrow transplant. Now, in addition, we have the problem that thalassemia and sickle cell disease happened on the main of patients who have an African or Middle Eastern or Asian background. And unfortunately, the reality is that our international registries are not very well representing those populations. And so it is difficult to obtain a fully matched unrelated donor for these patients. And that means that ideally we would like to do a transplant with the donor own cells, because then we remove at once the main complication that interferes with the success and the normalization of the quality of life with a bone marrow transplant. Now, one thing that we know about hemoglobin disorders is that their presentation doesn't happen immediately at the birth of the patient. Both thalassemia and sickle cell disease happen because of errors in the beta globin chain. The hemoglobin is formed of both alpha chains and a second type of chain, which has to be either gamma in fetal life or beta in adult life. And the reason why we think that we have different type of chains in fetal life in comparison to adult life is because it has a slightly greater ability for the oxygen and is able to steal the oxygen from the hemoglobin of the mother. But once you are born and you are breathing normal air, it's unnecessary to continue with fetal hemoglobin. And so there is a gene called BCL11A that represses further production of gamma chains, and it leads for that hemoglobin to transition to the adult type. And so what we are able to do with the CRISPR-Cas technology that was explained in a way by Uta is that we are targeting the enhancer region, that promoter region of the hemoglobin gene. We are targeting it and causing cuts. We cause indels in that particular region where the BCL11A will be activated by interacting with another gene called GATA1. And so if we create cuts at that erythroid enhancer, it means that we inactivate that gene. So BCL11A cannot do its effect, it cannot be expressed, and so there is no transition from fetal hemoglobin onto adult hemoglobin, and the patients go back to produce fetal hemoglobin because they are able to produce gamma chains, and they are therefore in the same situation they were in the first few months of life when, despite of having thalassemia or sickle cell disease, they no longer have the manifestations of the disease. And so that is what we have been doing in the pivotal XSL trials, the 111 and 121 trial for thalassemia and sickle cell disease, respectively, that we have been conducting among other centers internationally here at Imperial, at St. Mary's, and the Hammersmith. Now, the process is still that of a bone marrow transplant. It is simpler in the fact that once the cells are producing blood, there is no need to use complex immunosuppressive medication for 6 to 12 months post-transplantation, but it's slightly more complicated in the sense that there has to be a way of collecting the patient's own cells so they can be taken to the laboratory and edited so that they go back to producing hemoglobin F. And so that is what I'm showing at the top of the schema. So there needs to be a way of collecting stem cells, which we do with using G-CSF and plerixafor, which are medicines that are mobilizing the stem cells on the bloodstream. We put the patients on a special apheresis machine, collect the cells, and then they get shipped to the manufacturing facility. That collection normally happens over 5 days of medication and 3 days of collection. And the editing of the cells takes approximately 3 to 6 months. The actual editing doesn't take very long. It can be done in approximately 2 weeks, but there are very strict quality controls tests that need to be done after that. Now, in the case of thalassemia, it's fairly straightforward because the medicines that we have available to mobilize the stem cells are able to move those cells very effectively. The problem is that G-CSF in sickle cell disease leads to very severe crisis, and therefore we have to rely exclusively on the use of plerixafor and in preparing the patient very well with a particular use of red cell transfusions. The patients then get chemotherapy. They get high doses of busulfan intravenously, which still has the risks that any transplant has of infertility and the possibility of dying during the transplant process. There is a risk of up to 5%. We then infuse the stem cells, and we have to wait approximately a month for those cells to start producing blood again. But then effectively, around 3 months or so after the procedure, blood production has normalized, and the patients don't need to continue to have immunosuppressive medication. So the actual process is less complex. And the patients I have treated have all been able to incorporate themselves into the workplace or into the studies by around 3 to 4 months post-transplantation. Now, this is to show you what are the results that we obtain with the use of this technology. So what I'm trying to show you there is that the patients are able to maintain a normal level of total hemoglobin in the dark blue, which most of it is due to fetal hemoglobin in the lighter blue. And that is being produced by the gene-edited cells. And we have analyzed the patients between adults and children, because children are far more difficult to, or younger people. The data I'm showing you here is down to the age of 12. Younger people are far more difficult to implant stem cells because they have very expanded hematopoietic compartment, which is very, very cellular. And so it's not that easy as in an adult to be able to establish the new cells. And yet, despite of that, you can see that there is no significant difference between those who are adolescents from adults, and seems to be working well across all ages. Now, the other particular benefit of using this technology is that all the cells that the patient is producing are producing the hemoglobin F. It's not like when you do transfusions on a regular basis that the proportion of the cells will be normal cells from donors, but the other cells have the disease and will lead to manifestations of the condition. All the cells, as you can see here, over 90% of the cells are producing hemoglobin F. And so that is particularly important when we work with sickle cell disease. And if you focus on the right-hand side, in sickle cell disease, we are competing those alpha globin chains for both the new gamma globin that is reactivated by the use of gene editing, but the patients still continue to produce sickle beta chains. It's not like in thalassemia where there is no hemoglobin production at all. And so if you reactivate a new type of hemoglobin, everything will be the new type of hemoglobin that you have created. In this case, we have to compete the new hemoglobin F reactivated by the product with the patient's own beta sickle cells. And so we reach a situation where only half of the total hemoglobin is the gene edited hemoglobin F. And this is a situation which is analogous to having a sickle cell trait instead of having the disease. And in addition to that, having hemoglobin F in every cell, or virtually every red cell, means that even that remaining sickle hemoglobin cannot polymerize because the hemoglobin F inhibits it, and it cannot cause the disease. And so this is the clinical outcome in the patients. So what you see there is the red line in the middle is the point at which we have done the transplant. The blue dots are the regular red cell transfusions that the patient was receiving. There is a washout period of 60 days because we want to characterize the patient when there is no interference from donated red cells. And the green is the period that the patient has remained transfusion independent. And you can see that 49 out of the 52 patients did not require transfusions for consecutive 12 months. So this was not a brief effect of the gene-edited product. It is consistently maintained. And the 3 patients who you see in red, because it took them a while to reach that point of transfusion independent, had an 80% reduction in the number of red cell units that they required. And indeed, eventually, as you can see, all of them have reached the green area of not requiring further red cells. In the case of sickle cell disease, I have picked up a different clinical outcome. I have what we see there is the number of hospital admissions because of the vaso-occlusive manifestations of the painful crisis of the disease. So the left-hand side, in blue dots, you have every time where that patient had been hospitalized due to a crisis. The red area is where they received the bone marrow transplant with the gene edited cells, and then the green is the period of time without any hospitalization. And so you can see that 97% of those patients reached that point. Those that didn't was a brief event associated with a significant viral infection like parvovirus that reduced the red cell production, but it was not a sustained situation where there were repeated hospital admissions, showing you that in the majority of the patients there has been a functional resolution to the disease. And this is not just a matter of looking at laboratory values. It's not just a matter of seeing less hospital admissions or transfusions. We actually have good quality of data demonstrating that it does indeed make a difference to the patient. So the two squares at the left-hand side shows you the quality of life in adults. The little dots that you see there is the point that has to be crossover so that that improvement is clinically meaningful. And you can see that that happens over time, whether you look at it from a hematological quality of life point scale or from a bone marrow transplant specialist scale, which is able to capture better the signs and symptoms of somebody who has a bone marrow transplant. Now, what excites me particularly is when you look at the right-hand side, when you look at the adolescents, you can see that the fivefold change in quality of life is even more marked. And that is seen across all the functional areas that you will expect them to be particularly important for a young person, things like social interactions, emotional scores, and the ability to perform in a school. And so this might guide us when we need to think as to whom we should prioritize. It may well be that we need to think at a relatively young population who is going to get the greatest benefit, not just in laboratory values, but in functional scores in their life. Now, going to now bring a couple of challenges in relation to sickle cell disease. But before that, just let you know that so far there have been no events using this technology that has led to any cancers or unexpected new disorders. Most of the complications, and of course everybody who has this type of technology will have adverse events because we are doing a transplant procedure, are related to what you will expect in an autologous bone marrow transplant that has been conditioned with high doses of chemotherapy. And those side events, those adverse events happen on the main in the first 3 months, as you will expect with a transplant. Now, particularly in thalassemia, there has been a 12-13% risk of veno-occlusive disease, which is the main expected complication due to the iron loading and fibrosis that occurs in the liver of this disease. So this is in keeping with what we expect in transplantation. In sickle cell disease, there has been a case of a death. It's the only death that has occurred in the program on a patient who died 8 months after the transplant in association with COVID, in probably having had lung damage due to the use of busulfan beforehand. So the technology appears to be consistent with a transplant with a mortality risk, which is equivalent to having a transplant from a brother or a sister. So we are being able to deliver for those patients who don't have a brother or sister a transplant procedure which is as safe as having a sibling transplant. But we need to put it in context of what else there is available. And so in sickle cell disease, I have been working with a team in Vanderbilt to try to develop transplants for those who don't have donors, in a way that we are able to transplant people with 50% matched donors. And virtually everybody will have a father or a mother, a brother or a sister, maybe a cousin or an uncle, somebody within the family, which is 50% matched to them. Now, I'm very proud to say that the technology to enable transplantation across the HLA barrier was first identified in the 1960s at St. Mary's Hospital by a pathologist called Dr. Berenbaum, which realized that if you were to give doses of cyclophosphamide at very specific times post-transplantation, you were able to enable the stem cells to survive, whereas you were removing the immune system cells that will otherwise cause a rejection or cause the newborn marrow to attack the patient and create tolerance long term. Now, this technology has been grasped by Johns Hopkins University, and then we adapted it to hemoglobinopathies. But the basis of it comes from the work that was done by Dr. Birnbaum in the 60s. And this year, we've been able to present and publish both the collaborative learning group of our work together with Vanderbilt University, what we call BGC2, and also a phase 2 multi-center trial done in the States, the BMT-CTN 1507 trial. And what both those studies have demonstrated is that you are able to obtain very high rates of cure with the use of post-transplantation cyclophosphamide in adults with sickle cell disease. You can see that the overall survival is almost identical between the two groups, with a very high cure rate of around 90 to 95% at a cost which is substantially lower than what you expect for the gene therapy technologies. And this type of transplants are done not with high doses of myeloablative busulfan chemotherapy, but reduced intensity in a way that any patient, even when they have a degree of organ dysfunction, are able to tolerate it. And so we do have an approach to transplantation that we can offer to adults where there is no high dose exposure and which works, although undoubtedly is a far more complex process, required a year of management of immunosuppression treatment. Now, the other challenge that we have with using gene editing technology, like with any other gene therapy, is that you have to be able to obtain a sufficient number of cells in order to be able to edit them. And whilst patients with thalassemia on the main were able to achieve that point with just one cycle of apheresis and collection of the cells. In the case of sickle cell disease, the median was 2 cycles, and a third of the patients required 3 or more cycles. And indeed, around 10 to 15% of the patients are not able to mobilize sufficient number of stem cells to have the gene editing technology. There is also a problem that a proportion of patients with thalassemia will have concomitant alpha thalassemia, and where more than one alpha gene is affected, then you cannot apply the gene editing technology. So there's still subgroups of patients for whom the technology is not quite available. Now, what can we do in the future? A couple of words as to what is coming. One is to use a different Cas technology. Instead of Cas9, use Cas12, which is of a greater efficiency and probably minimizes off-target effects. The second thing is to, instead of edit the enhancer of BCL11A, to actually edit where BCL11A targets the promoter of the gamma chain itself, which is what occurs naturally in patients who are able to have persistent hemoglobin F. And this is early data from the EDITAS trials, and you can see that that improvement in efficacy may actually have higher levels of hemoglobin F production. So with the Vertex product, with the Exacel, we were obtaining hemoglobin F levels somewhere around 42, 43%. With this technology, you can go potentially higher, maybe 46, 47, 49%. Now, what I don't know is whether this is just going to be a beauty context in which, everyone shows that you increase a little bit higher the hemoglobin production, but is this truly translated into clinical benefit? I don't know. And it may well be that actually the most important thing is to reach a particular product that can be manufactured
at a cost-efficient way. And so, all of us would love to have a Ferrari or a Rolls-Royce, but actually we are very happy driving a Volkswagen because it does its job. And I'm not completely sure that maximizing efficiency of the technology is what is going to ensure that long-term this is going to be used. It may well be that reducing cost and making it available is far more important. And then finally, the risk of using CRISPR-Cas technology as it stands is the fact that it causes double-strand breaks. So we are creating indels to disrupt the sequence. And so potentially there may be a risk there that you may alter the sequence of your genes, create translocations, and create a problem for the future. So there is where base editing comes in. So we are able to use the CRISPR-Cas technology not to create double-strand breaks, but to actually alter the sequence of the genes. And by altering the sequence, you can create a particular region into a nonsense area and still reactivate the hemoglobin F. And you can see this is laboratory data of Beam Therapeutics in which they are able to obtain very high levels of hemoglobin F. We're not talking about 40s, we are talking about 60s with reduction in the overall production of hemoglobin S, thanks to taking this approach. And this is something that hopefully we'll be able to test in patients very soon. So I hope I've been able to show you that we are able to obtain very robust, durable increases in total hemoglobin that I haven't shown you the slides, but they are persistent. The allelic editing is long-term, and we are probably truly addressing it at a true stem cell level, and that there are both clinically minimal improvements in the manifestations of the patients, but we also have good quality of data that shows that it does truly make a difference to the patients.